Dr. Stephanie-Roxanne Blanco is a neuropsychologist, senior lecturer, researcher and consultant specialising in functional neurological disorder. Perhaps as relevant today is the fact that she's the Vice Chair of FND Dimensions, which is a UK charity dedicated to supporting those with FND, and hopefully we'll be finishing off our series of talks talking about some aspects of the patient perspective. Thank you very much.
Thank you. So it was 19 years ago that I was left unable to move. I was left without a voice. I was left with no ability to move. And it was the first time that I felt voiceless in FND. But it's certainly not the last time. For those of you who don't know me, hello, I am Steph Blanco. I'm now proud to add doctor to the front of my name because my amendments were submitted last week. Finally, after 6 long years, they are done. And I am the Vice Chair of FND Dimensions, so I work in a community sense as well. But obviously, I also have lived experience of FND. And you'd think that with all of this experience, with all of these different roles, that I would now start to feel like I had a voice. Obviously, my voice is stuttering already, so clearly not that much of a voice. But also, I have this paradoxical experience of having felt quite voiceless in most of those roles. As a researcher, I'm often told that lived experience is not scientific enough. It's simply, just patient data, and that's pretty meaningless in scientific terms. In terms of my role in the third sector with patients, I'm often trying to work with systems that fail to consider a joined-up approach in terms of meeting those with FND's needs, and working with the third sector and with peer support to enable that to happen more easily, better, more effective. And as a patient, I'm sometimes misunderstood, discriminated against even. That experience I just explained 19 years ago when I was lying in a hospital bed and unable to talk and move, consultants were talking over me, describing how I was a teenager and just doing it for attention. Later on, as in Kim's experience, I was told to just have some wine and have a nice chilled evening. It's an odd amount of times that that's recommended as a solution. But I'm not the only one that those experiences have happened to, as we've already heard, and it is continuing today. Whilst my experience was 19 years ago, we still regularly hear these comments in community groups and in third sector work. But we've also heard today about services that do exist, things that do work. The research is there, the evidence is there. Okay, I'm not going to shoot all my funding calls down just now and say that we don't need to do any more research. Of course, we do need to do more research. But we know that the evidence exists already to start to work in a joined-up way. The thing that is missing for me from those joined-up approaches so far is patient voice and patient experience. And without that, we do remain stuck in misunderstanding. And I'll go on to share some reasons why I feel that way. Most importantly, lived experience for me is critical evidence. And there are ways to look at this scientifically. I've shown that throughout my own studies and incorporated not just my voice as a patient, that would be a little bit too easy and a little bit too biased perhaps, but I have included other patient voices and other patient experiences to inform my research practices. I also include them to inform the services and the provisions of service and support that we use at FND Dimensions. But historically, lived experience has been ignored. It's been treated as not real data. I do remember reading one paper, for example. It was a clinical case study. The clinical case was pretty similar to my own history and my own journey of FND, so much so that I'm not entirely convinced that that paper was not written about me. But it was written in this cold language, and it was written in a voice that wasn't mine. It was my experience, but written by somebody else. And actually, the things that they felt, the things that they saw, the things that they assumed about my experience were not entirely true. And there were some big assertions in that paper. If it was about me, of course, it might not have been. And it's also that it's said to, research in general, I think sometimes we get really far removed from the reality. of lived experience. And I say that because I come from a background of psychology, particularly experimental psychology, and we do all these weird and wacky things in the lab. And originally my PhD started out with all the fancy motor paradigm models and EEG and TMS and all the rest of it. But actually that doesn't account for lived experience. It doesn't account for how people experience their symptoms in the real world, in the real setting outside of the lab. And I feel like if we want to truly move forward with research, with reducing misunderstanding in research culture and in clinical practice, we need to accept that lived experience is critical evidence. It shouldn't be an afterthought and something we just do afterwards to evaluate something. We should consider it as we're building those services in the first place. I did think I'd show that I do some research. I didn't stick a published paper on there. Instead, I stuck a model in from my PhD. And this is the model that I proposed towards the end of my PhD. Quite boldly, I thought. I just stuck it in there all the same. And it is obviously just based on the data that I had from my own PhD. It doesn't consider the wider implications as well, though I do discuss that later on in the thesis. And my PhD was needlessly complicated. This is only half of the things I had planned. I went on very many tangents during this journey, probably why it took me so long as well. The core things that I experienced and that I focused on were things like inflammation, dissociation in particular, and brain function as well, mostly measuring through EEG. But the reason I'm highlighting this model is not just to plug my own work, but it's to show that FND goes beyond being a brain network disorder. It influences the whole body. It influences emotion. It's tied up in subjective experiences, as has already been mentioned. And one of the things that I tried to do throughout my PhD was take an aspect of each one of those elements and incorporate it. At the time that I started my PhD, not very many people were talking about dissociation. And if they were talking about dissociation, they were talking about it as a precipitating factor in the development of the symptoms. But what I did instead was look at it as an outcome measure and see FND as dissociation as a potential outcome measure and its interaction with things like neural network dysregulation and inflammation. I won't tell you too much about the study's findings because I am trying to publish them and I don't want to give the game away because I'd like you all to download it and talk about it. Even if those are critiques, it will help me to get my citations up, so that would be appreciated. But I wanted to bring this in because right now, the way we are treating FND is still in a fragmented approach. And if I've been able to incorporate it in research, we should be able to incorporate it in clinical practice models as well. And because, at the end of the day, these factors are all influenced by one another. So if we start treating dissociation, that's not reducing inflammation. And inevitably, that means that neural dysregulation is still going to occur, symptoms are still going to persist, or they're going to change slightly in variation, and inevitably that patient is going to end up back in the clinic, either within that same service or within a different service with a different functional complaint instead. Inevitably, we're just creating a perpetuating cycle where we're not actually effectively treating the symptoms in the right way. And I think when we talk about a teamed-up approach, we need to also think about a combined approach, an approach that is supporting patients with all of their symptoms or a collection of those symptoms at the same time, because sometimes some of them influence the other symptoms, and that's rarely ever talked about. One of the other things I then went on a bit of a tangent about, as you do, is I started to talk about mood and try and incorporate mood elements, remembering that I was a psychologist and incorporating those. I talked about chronic illness burden as well an awful lot during my PhD, and starting to try and disentangle chronic illness burdens and social and environmental impacts and factors as well that are perpetuating that cycle further and that are influencing that cycle further. And again, I feel that those are things that are not often talked about and not often talked about in a clinical sense, but they need to be incorporated, and that is where the third sector can come in and support. That is where we can embed things like creativity, social support, peer support, and reduce that burden on some of the services that are already existing. I then went on a further tangent and decided to do some latent class analysis to try and identify subtypes of FND, and I'm going to not tell you about those just so you, again, download that paper, please, well, as soon as it's published. I thought I'd talk about solutions to FND, and in my typical style, I'm not going to do it normally. So I'm going to talk about it from a vanilla ice approach to FND treatment, and I can't take all the credit for this. This idea was a joint venture between me and a neurophysio who works in private practice at NeuroOptim Physio. This was one of our attempts to raise awareness on one of the awareness days. It was later taken as an idea in Frontiers, and we weren't given the credit, so that's okay. But the whole idea behind this approach for clinicians and researchers would be to start, to listen to the symptoms that people are experiencing with FND, and not assume that FND fits neatly into a little box. Not assume that it's the responsibility of one specialist or someone else's responsibility to avoid patients being sent backwards and forwards between different services. I think we need to collaborate. I think we need a true MDT approach, but I also think that patient voice should be heard within that approach. I think that we need neurology, physio, psychology, OT, speech, and patient-led support as well. I think all of those things are vital if we're to move forward, and more. And I think we need to listen. I think we need to listen to the narratives of patients in a clinical setting, as well as in research settings, and enable them to be active partners in the service design and research, not just passive recipients of care. I think for a long time we have felt voiceless as a community, and it's why we often leap at the opportunities to come and do talks like this, because we want to be heard, we want to be included in the conversation, and we do have the skills necessary to be included in those conversations as well. For me, a gold standard FND service isn't just about professionals. It's also, it's not necessarily just about individual professionals. It's also about removing some of the barriers that exist to teams working together. What we've seen today is different standard documents from different specialties, and what we have got as well is a lot of fragmentation in kind of stopping us from working together collectively and as a community. And I think it's about working together in a way that makes sense for the patient as well, so that they see that they are in an FND service, not that they're being bounced from pillar to post. Because that perception of them being on another wait list and not knowing if I'm going to get to the top is inevitably just making them worse, and altering their perceptions as well of how FND is viewed by clinicians. Right now, I feel like we are making some positive changes, and there are certainly some steps forward. But in terms of the reality for our patients, FND service care is still, service provision is still reactive. It's not being proactive, and many patients are still saying that they are left without support. They've been trying, they are still on wait lists, and we know that's not the fault of necessarily anything that's happened, or like anyone that's working in this area knows that wait lists are that way for a reason, because we're still lacking resources, we're still lacking funding. But I feel like if we have a more joined up approach, it will certainly help. I mean, at the end of the day, patients bounce between A&E, they undergo multiple tests multiple times, they have multiple referrals, long wait lists. All of this is costing an awful lot of money. All of this is very ineffective. Whereas if we had early intervention, that would lower costs overall. It improves outcomes, it reduces long-term disabilities as well. I was going to say we don't need more research to tell us that fragmented care is expensive, but I don't want to cut any more of my funding chances, so I won't say that bit. So for me, the roadmap for change is that we do need to implement MDT clinics, but we need them on a nationwide level. We no longer want the postcode lottery approach. We no longer want to hear that people are out of catchment for a service that really they should be going to. I do want to see mandatory FND training in medical and clinical curriculums. Now, I know increasingly this is being embedded in some specialisms, but for example, I still teach in psychology, and it's not yet part of our overall curriculum. I feel like it should be, no matter what area of health or social care or medical practice you're working in, you're likely to come across people with FND. We need more integrated care pathways, and obviously we need policy and funding reform, but also to integrate third sector working as well. We have some really creative ideas, we have some really unique designs, and we feel like we could really support in the development and further research as well. And I will leave it there for me for now, but thank you very much for listening.